Welcome to the Protein Bros podcast. Today on the podcast, this is one of my favorite podcasts we've ever done. Not only does the podcast guest today have an awesome name, his name is Kyle Gillett, but he's also one of the smartest individuals I've probably ever spoken to. Kyle is a board-certified physician that specializes in obesity and hormone production. He is a hormone specialist. And on today's podcast, we get into the weeds talking about testosterone levels, how to increase naturally testosterone levels, what's going to help with quality of life when you're looking at a hormonal panel, what supplements make a big difference in improving quality of life and improving longevity. And then we also talk about SARMs, hair loss. I mean, this is a pretty in-depth podcast, and I'm going to warn you that we talk a lot about a lot of technical stuff throughout the podcast, but I think the information that is in here is some of the best information that's ever been put out on this podcast, and I am so excited for you to hear it. So let's get to the podcast.
I can't remember if there's Kana in that or not. We're having to change the name to like the branded Zimbrin or Silentium torticum, because Kana is the name is getting blacklisted.
Oh yeah.
Yep. Even though you can use the same exact active ingredient and still list your product on Amazon.
How do you keep up with what's being banned and what's being blacklisted and all of these?
Mostly I don't. Mostly people just tell me.
Yeah. Yeah, it's kind of impossible to keep up with them, And plus, it seems like there's not a lot of rationale behind some of them. Like when they were trying to ban NAC, I was like,
yeah,
what are we doing here? Like,
we used to have this product called Rush, and it had a bunch of stuff in it. I still have several bottles, but that is one of the most hardcore stems that you'll find in a supplement.
It's called what? I'm sorry?
Rush, Gorilla Mind Rush.
Okay.
Yeah.
That's amazing. Do you formulate all of those products?
I wouldn't say I formulate them. It just kind of started as a hobby, and now I do it as a job. Yeah. But I'd say I have input into everything.
Awesome, man.
You guys are blowing up, man. It was that brand became one of the most highly requested brands we've had in the last probably 2 or 3 years. It was like, and then Brandon. I don't know if you know our purchaser, Brandon, but I think we're one of your first retail accounts, and Brandon became. I don't know who the guy is that does your guys' wholesale stuff, but I think they became pretty good friends through the process because you guys were ready to kind of make the move into retail along with just being sold direct to consumer.
Mm-hmm. It took years for us to create that relationship just because of how many, the amount of young people off TikTok that were requesting it in our store. It was genuinely mind blowing.
Yeah. I get kids, usually teenagers, and they'll come to the gym and they'll say like, "Hey, I saw you talk about peptides on TikTok. What should I take?"
You're like, I don't know, is that good or is that bad?
Yeah, TikTok is great for just like reaching the general public.
Yeah, getting at
what the ethos is of the average individual.
It is kind of crazy how something can blow up on TikTok now, and it's something will blow up on TikTok and like ashwagandha just did this where it blew up on TikTok, and it actually creates a shortage in the supplement market. So we're buying our normal amounts of ashwagandha. I increase it by like 30%, and then I go to increase it, and it's like, hey, we have none left because everybody's buying the crap out of ashwagandha.
Yeah. Specifically KSM 66.
And I'm like,
KSM 66.
Yep, KSM 66. And I'll be like, why is this happening? They're like, it's TikTok, man. I'm like, oh my gosh.
You know what effect that used to have was Dr. Oz. Whenever we were
similar,
when Kyle and I were working the locations, when TV and Dr. Oz was still at an all-time peak, people were coming in for stuff that we had been selling for a decade, and no one came in for it ever. And then all of a sudden, we just can't even keep it in stock, and it's all just green coffee bean extract or
raspberry ketones.
No, dude, the other one was Garcinia cambogia.
Yeah,
remember that one at all?
Yeah.
Oh man, is that stuff that you ever put in a product yet?
I don't believe so. But I know that there's, even within ashwagandha, like different varieties of the root, stem, and leaf, depending on the proportion. Shodan blew up at one point, and then it was Sensoril, now it's KSM 66 again.
Yep.
Mm-hmm. But yeah, a lot of times the raws come from the same place. So you HPLC it and standardize it, and it's like, well, you can pay for the branded or not pay for the branded, but a lot of times you just pay for the branded.
Yeah.
With all the ingredients that you've looked at to help with formulating a product, is there a certain ingredient that really stands out for you where everybody's under the assumption that it's just the same as everything else, but the quality of the ingredient, there's a massive change in that, and people wouldn't know the difference.
That's a good question. Anything with low bioavailability. So for some things, liposomal is very important, but then it becomes more complicated because sometimes you don't want it to go systemic. You want it to work in the gut mostly. Like quercetin is a good example, or even curcuminoids. Some quercetin, you want to it's a monoamine oxidase inhibitor, a weak one. So some people have...
For our listeners, are you able to put that into layman's terms?
Yeah, it can cause you to be overly stimulated. Okay. Almost like if you take too much of a serotonergic medication, it can cause you to sweat too. But it also helps stabilize mast cells. So it can do that in the gut, which can be beneficial, but then it can also do it systemically. So liposomal quercetin might not be what you specifically want. Same thing with curcumin. So some curcuminoids are 5-alpha reductase inhibitors. Some of them are not. And depending on the person, you might want that effect systemically, or you might not want that effect systemically. And it's not just like liposomal or micellar distribution. It's also if it's complexed. So there's some things that are normally in oil immersion, like ubiquinol or branded CoQ10s, but they're also bioavailable even in powder form, not in a gel cap, if you have a microactive or basically complex. Ecdysteroids are the same thing. So most ecdysteroid powders are just placebo.
Really? So you're not one of the people that thinks that liposomal is useless. I don't know if you've seen that on the internet or not, but there are people out there that say that it's a waste of money.
In most cases, it's not needed.
Mm-hmm. Can you give me some ingredients for those at home that you would feel like it is necessary?
Probably NAD+. There's a lot of anecdotal evidence, and some people swear by it. The clinical evidence is mixed. I think a better option in many cases is nicotinamide riboside or nicotinamide mononucleotide, which is NMN and NR. But some people really like their liposomal NAD+.
It's very... The thing that, in our industry that gets confusing is when you get into, ingredients and specifically when we're talking to people about like the different forms of ingredients and how to parse them apart. On top of, you have very limited funding and studies that go into a lot of these ingredients specifically. When you're looking at like a new ingredient, what specifically are you looking for? Like how much data are you looking for before you can actually recommend it? And what kind of data are you looking for? I guess you could talk about the different types of studies that you look at as well.
Yeah, so the process is actually very similar to finding a new medication. So there's different stages of clinical trials, not for supplements, but for medications, but some supplements are repurposed. Like they're trying to take beta NMN and also NAC and make them into medications. So first you have stage 1, then you have 2, 3, then it generally gets FDA approval. Then you have stage 4, and then it's kind of murky. And we've done a podcast. Gillett Health has done a podcast on this too, because sometimes they'll have 2B/3A. But the general thing is 1A is establishing pharmacokinetic and pharmacodynamic data, which is basically what the supplement or medication, what the effect is, and how it's metabolized, and then pharmacodynamic data, which is the drug or the supplement's effect on the body. And then after that, you go through stage 2, and with stage 2 and stage 3, you're looking at both the safety and the efficacy, and also usually in stage 3, you're using controls. So a supplement is pretty similar.
Mm-hmm. I'm sure we'll come back and talk more about supplements here in a little bit, but I want to get back to, or I guess want to circle back around to, specifically what you do as a doctor. You're a hormone specialist. You're also an obesity doctor and specialize in obesity health. What made you want to go into those fields and want to study that specifically?
Yeah, so my dad's also a doctor, and he still practices at College Park, which is a local faith-based healthcare group. And he did what I'd call full spectrum medicine. We're, I guess, lucky here in the Midwest. Maybe that's not the right word, but doctors still do a little bit of everything. They deliver babies, they do vasectomies. And that's kind of one of the last of the Mohicans on the coast Doctors really don't do that.
Everything's specialized there.
Yeah, they're like robots, and they go by an algorithm. And if it's not according to the algorithm, then sorry, it's not possible. So I really liked that. He also practiced holistic medicine, which is basically body, mind, and soul. He prayed for his patients. I'm a Christian. And I liked that he didn't ignore the mental and spiritual aspects of a patient. So I designed my practice, or I designed my education so I could practice that way.
That's
Nice.
awesome, man. I love the intentionality behind it. I think a lot of people go to school with the thought of, I just want to be successful. I just want to be able to have a job. It's a means to an end. It sounds like you've had a lot of intention behind how you were educated and what you wanted to do with it. That transition that you had post grad, what was that like? And I would say, is there a memory that sticks out to you when it was just really freaking hard compared to how it is now?
That's a good question. It was the beginning of residency was pretty difficult, but necessarily difficult. The beginning of practice after residency, I fortunately knew what to expect. We don't have to go into details about the problems with our healthcare system. I guess we could.
Well, I think that you're to this point, Kyle, you are our only guest who has the background that you have. And so I think it would be really helpful for our listeners if you could give a little bit of just like a very wide swath of what we're facing every day.
Yeah, so there's a high amount of burnout in medicine among nurse practitioners, PAs, and physicians, medical doctors. And part of the reason is they're not given the tools to care for a patient how they want to when they go through medical school and residency. In med school and residency, we're taught to do things like active listening, which is listening how the patient would listen if you were in their shoes. That's what empathy is. And we're taught to do what's called shared decision making, which is explain the various options. If there's more than one reasonable option, tell them the benefit, tell them the detriment, and then come to a decision together rather than just telling them it's my way or the highway. That's called medical paternalism, which is what we used to do. And in med school, one of the most popular groups is exercise and medicine. One of the other ones is food is medicine. However, as patients get out and, there is a huge supply for healthcare and a huge demand for healthcare, but the demand outweighs the supply because people are very sick, mostly because of poor lifestyle, but other reasons as well. And because as you go through residency and then start practice, you realize you have 5 to 10 minutes with the patient. And even if you wanted to do something, insurance is not going to cover that. And it becomes very frustrating.
Yeah, it starts to feel like you're not set up for success to genuinely help the client.
Yeah. When you're meeting with a client for the first time and they're interested in increasing health span and, increasing lifespan, so increasing the quality of their life and then how long they're going to live, and you're looking at somebody's hormone panel, what is the specific thing that makes the biggest difference in somebody's quality of life when you're looking at like a blood panel or you're looking at a hormonal panel, and also the longevity that the amount that they're going to live outside of obviously genetics?
From a standpoint of what you can do, it's always lifestyle interventions. I call it as the pillars of health. Mm-hmm. Diet, exercise, sleep, stress, spirit, social health. From a standpoint of, and maybe this is the question, what can you do or what should you test that is the highest yield intervention? Yeah, I guess I'm asking, is it testosterone? Is it are you looking at your cholesterol levels? Are you looking at endocrine system like the thyroid hormone production, T3, T4 hormone production? What specifically, I know it is kind of all encompassing and you kind of have to look at everything in a big picture, but like what are the most, what's going to dictate somebody's quality of life and then longevity of life the most when you're looking at a blood panel? Those would be anything that would, let's call it a nuke to your system. Mm-hmm. Anything that is going to arguably irreversibly decrease your quality or quantity of life. Those are things like hemoglobin A1C, which your regular doctor may or may not check regularly. Fasting insulin, I would argue, is another one. Extremely high ApoB, potentially even extremely high Lp(a), which are 2 lipid particles that can put you at risk of heart disease. Yep. Those are probably your main ones, but
Is the fasting blood glucose if you're diabetes or you have the tendency or the possibility of getting diabetes?
Yes, that would definitely be one. But most of the time, before you have a fasting blood glucose over 126, you'll see the A1C and the insulin raise up before that. As you mentioned, testosterone, estrogen, estradiol is your strongest estrogen. If those two are very low when they normally would not be, those will likely significantly affect your quality and or quantity of life. Testosterone, more quality of life. Estrogen, more quantity.
It's very interesting to me because, with testosterone, I've read a lot of different things saying that, in the last 20 years, testosterone across the board has dropped up to 25% in males. As being an obesity doctor, I've always in my head kind of correlated the rise in obesity with the decrease in testosterone. But are there other factors that play into that? You also read things about like plastics being in, there being different endocrine system disruptors. How much of that is true and how much of that do you think is just purely based on us as a society just being over fat or being more obese and having poor lifestyle?
I'd say that slightly more than 50% of the cause of low testosterone now compared to in years past is due to two things, and that'd be metabolic syndrome and sleep apnea. Sleep apnea, even in the absence of metabolic syndrome, can cause low testosterone, specifically low total testosterone. A lot of times if you have, let's say you have prediabetes, insulin resistance, and a fasting insulin of 15, which is pretty high, fasting insulin, it is likely you'll have a low SHBG, which is a protein that binds up hormones and prevents metabolism. So you're probably synthesizing and making a normal amount of testosterone, but your total testosterone looks low because it becomes metabolized quicker than average, and your free testosterone might be normal. Mm-hmm. Conversely, if you have an imbalanced diet, or let's say you overtrain and you're very lean and you don't eat a lot of fat, you just eat protein and fiber, you might have a normal looking total testosterone, but a very low free testosterone.
So for everyone who's listening, can you give people an understanding as to why free testosterone and total testosterone are basically two different readings, and then also what is considered to be physiological with those? Like what's the ranges of both of those?
Yeah, so with total testosterone, that is any testosterone. It could be bound, it could be unbound, which is free. It could be bound to SHBG. SHBG binds all androgens very strongly. There's only one androgen receptor that we know of. So basically the effect of any androgen, for example, testosterone or DHT, dihydrotestosterone, they bind the same receptor and they cause an effect, a genomic effect, whether it's muscle growth or hair growth in certain areas or lack of hair growth in certain areas or prostate growth. But the SHBG can help deliver that to some tissues. For example, it facilitates delivery to the prostate, and you see SHBG raise as age progresses. Mm-hmm. So you think very old male, high SHBG, lots of testosterone delivered to the prostate hyperplasia. So total testosterone certainly helps with some things. Free testosterone in general is free to bind. And in general, if you have a very high free testosterone, there's plenty of testosterone to bind in tissues like muscle tissue, which is what a lot of people are interested in. Sure.
Mm-hmm. Yeah, but there's lots of, I guess, can you go over the other benefits of having healthy amounts of testosterone?
Yeah, one of the main benefits is it converts to estrogen. There's an enzyme called aromatase, and when testosterone is aromatized to estrogen, estrogen has a cardioprotective effect. We know that men that have very low testosterone and also very low estrogen have high rates of plaque buildup, and women who go through menopause early, so less estrogen over the course of a lifetime, they also have very high rates of plaque buildup and subsequently higher risk of heart attack and stroke. That's why if you take a male who is truly hypogonadal, also with low estrogen, you replace testosterone and they have less heart attacks.
It's amazing.
And that's basically you're prescribing that, or I'm guessing that most people are recommending that when you have under a 300 level of testosterone. Is that correct? Or is that dependent on person to person?
Yeah, it depends.
Yeah.
There's some people on one end of the continuum or spectrum that tend to not prescribe unless your total testosterone is 263 or lower.
What an arbitrary number.
Yeah.
Seemingly.
There's
263.
There's some that will prescribe. An insurance company, by the way, a lot of endocrinologists, especially on the coast, usually go by either 2 or 3 morning level. They usually say fasting morning. Fasting does not matter, but 2 or 3 morning testosterone levels, because it does drop as time progresses, especially in younger males. Older males, it's more stable throughout the day. Younger males can have a more precipitous drop throughout the day. And then insurance companies usually go by 300. So if you're trying to convince the insurance company
to cover it.
Yeah, it's called a prior authorization. And then after that, if it fails, you appeal. Then as you appeal, you can also do a peer-to-peer, which is where you talk to a doctor that works for the insurance company, which must be a fun job.
Yeah.
I feel for some of them.
I can only imagine.
Yeah, so with most insurance companies use a cutoff of 300. So 2 different morning levels of total testosterone, 300 or under, they'll cover your medication. But if you have a total testosterone of 302, but a very, very low free testosterone, let's say you're a keto dieter or a carnivore dieter, that tends to be the case. You see low free T, high total T, then they won't cover it. Most urologists, and I believe the AUA, which is the academic society that most urologists are part of, I believe they still use a cutoff of around 400 total, and again, 2 readings. And I would put myself more along the lines of
400. Sorry to cut you off, Jeff. I've gotten my testosterone checked before, and it was like 250, and I was probably like 31 years old. What is the range when you say that it goes up and down? Because when the doctor got my blood work back, he was like surprised by it, and he's like, "Is your sex, is your sex drive low? Are you feeling? Is your energy low?" He was going through like all the things. I was like, "Man, honestly, I feel great." If you wouldn't have told me that, I would have never thought anything different of it. So he didn't seem concerned enough to make me come back and do blood work again. I'm assuming because he just figured that, I didn't get enough sleep, I was overtrained or something along those lines. But for somebody who is maybe in their early 30s or, in their mid 30s, how much is testosterone fluctuating, on a regular basis? Like, does it, go up and down 300 points, or is it more of a longer duration that it takes for testosterone to rebound if there's some kind of dip caused by lifestyle? What's your thoughts on that?
If you're a fast metabolizer and you have a very low SHBG, again, that's the protein that binds up all androgens and actually all estrogens as well, then it's possible if you got your labs taken at 4 p.m. I don't know if you remember when you got your labs done.
It was in the morning.
So there's not going to be a whole lot of fluctuation morning to morning.
Really?
If you get a bad night of sleep and then the next night you get a really good night of sleep, then maybe it'll go up 100 points, but it's not going to go up to 900. You might see a 250, a 350, a decent amount of variation. But it's also possible you could have checked it at 4 p.m. and it would have been 210. So I assume that you tend to have a slightly lower SHBG.
Yeah. With that, I guess that goes back to when he told me that, I was kind of disappointed in myself for not getting blood work done earlier and having like some kind of baseline established, is that something you recommend? Like how old do you recommend people start getting blood work done?
This is a question that kind of varies individual to individual. I'd say
to optimize for what?
Yeah, no later than 30, because at 30, statistically, your total testosterone will decrease by about 10 every year. Now, if you have good lifestyle, you can attenuate about 50% of that decline. But that's just average. So some people will drop even more than 10 per year. But I think it's very reasonable to check as early as 18.
Really? Okay.
Yep. And if you're having delayed puberty or slightly early puberty or something that just doesn't seem completely normal, then obviously with the consent of your parents, it's very reasonable to talk to a doctor about the risks and benefits of testing at that point as well.
What would you consider to be the number that someone who values exercise, who values a physical lifestyle, if you will, what would you want their number to be at for that healthy male?
Yeah, for someone that values health span, someone that wants to maintain athletic performance,
correct,
and also have like objectively improved recovery, I say a total testosterone of at least 550. That's someone that probably has a low SHBG, so their free T might be 20. And then a free testosterone of at least 15 or perhaps 12 in older ages, just because SHBG increases quite a bit. So a total of at least 550, but probably 600 plus, and then a free of 12 plus. And I think that seems extremely reasonable to put as an optimal level. It's very surprising, as you kind of implied, there is not a lot of correlation between high-performing athletes and total testosterone levels past about 400, 500. And it's not unusual, especially when someone is very lean. I know that there's a lot of individuals that have posted their testosterone levels online that are elite athletes. Thomas DeLauer, I know he has. Nick Bear, I know he has. And it's not always high.
Yeah. I know Lane Norton's done that too. And Lane Norton had like over 1,000 level, of total testosterone, which is pretty crazy because I think Lane Norton's late 30s or maybe early 40s. But yeah, it's kind of strange how, for me, when the doctor told me that, I guess the only thing that I really noticed was that maybe my top end strength was, like getting motivated for like a very heavy squat might be like where the only place where I would notice it affecting my performance, I guess. I have gotten blood work back since then, and my blood work was like 450, I think. And so I don't know exactly what was going on there. It could have been lifestyle, something regarding lifestyle as far as like sleep, or something along those lines. But I also, at that point in my life, might have had higher body fat percentage. And that could, can you talk about how body fat percentage plays a role in negative hormones? Specifically, I mean, you can talk about sex hormone, but does higher body fat percentage play a role in like thyroid hormone production as well? Like what I'm saying is if you have a high body fat percentage, is it damaging your metabolism even more?
Past a certain point, yes. In general, if you're between a body fat percentage of 10% and 20%, for nearly everyone, there's obviously exceptions that can perform very well at 5% and at 25% as males. And then for females, between about 20 and 32% body fat is that's generally your optimal performance body fats, and where you're going to see optimal and natural or endogenous production of testosterone. The three main things that you want to look at that are mostly explaining what varies testosterone is a fasting insulin. If your fasting insulin is high, you're probably at a higher body fat and you have relatively more insulin resistance. Insulin binds the insulin receptor in the liver, which directly decreases that production of SHBG. And anything that decreases SHBG is going to decrease total testosterone in general. There's always exceptions. Same thing with carbs. If you have a very high carb diet, if you're like doing a powerlifting meet and you eat a whole bunch of gummy bears or something, then your insulin's probably going to go high. And again, low SHBG, lower total T. If you decrease the amount of cardio you're doing, that will do the same thing.
My question that I had for you earlier when we were talking on testosterone.
When I interrupted you
several times.
So sorry, Jeff.
It's all good. But there's practical things that I think that, again, our listeners are going to be in fear of. Let's say someone is going to take testosterone. They're thinking all of the things, right? Like, so a classic example.
I'm going to get so jacked is what they're thinking.
Well, if you're like 30 if you're 30 to 40 years old, you get tested for the first time, you see that you have low T. They prescribe you testosterone. Typically, a general practice doctor will prescribe a very low amount, 100 milligrams a week, 150 milligrams a week, something like that. And that could do the job, or it could not. But the bottom line is when they do this, first thoughts are my balls going to shrink? Am I not able to have kids? Can you touch on those things? Is there real fears there for people who are taking low doses like that?
Side effects, basically.
Yeah. I love the concept of what the general public thinks about testosterone, because sometimes from my position, it's hard to forget what people generally think and what they don't think. I don't know if you've seen the iceberg videos.
Oh yeah.
But Friday we filmed, my podcast partner or co-host James and I, we did a TRT iceberg, and we got a whiteboard and we wrote every single question that people went in. And as you mentioned, those are things that are at the top of the iceberg. So basically, for those that don't know, and it's a meme too, it's a good meme template. Mm-hmm. If it's above the water in the iceberg, that's what you see. So it's, TRT and acne, you expect it. TRT and thick blood, you expect that as well. TRT and testicular atrophy, you can expect that. Some people it happens faster, some people it doesn't happen as fast. If you have varicose veins like varicocele, it happens faster in general. But there's a lot of things beneath the surface. So as you mentioned, your GP, they might be a boat captain and they're approaching the iceberg and they only see what's on top. They're not looking, or hopefully maybe they're listening to our podcast and whatnot, so they're looking beneath the surface. But there's a lot of effects other than that a lot of people don't think about. For example, a common one is iron deficiency. In general, you hold on to iron better, but a lot of people do a cookie cutter protocol where you donate blood or give blood every 2 to 3 months. And it is possible to have too many red blood cells, but not enough iron. So you can concurrently have an erythrocytosis, which is too many red blood cells, and be iron deficient.
Gotcha. What's the negative health outcomes for low iron over a significant period of time?
Yeah, leg cramps is a common one. So a lot of people wake up because they think their legs are restless, but they're really just iron deficient. Performance is pretty important as well. You have less oxygen carrying capacity. You can have small red blood cells. You might have a lot of them. That's called microcytosis. So that can be negatively affected. If you happen to be pregnant, there is correlation with low IQ of the offspring.
Damn.
So when you think of TRT, the thing that I think about when you're taking like super physiological amounts of testosterone is that there is issues that people will have with their heart. Specifically like cholesterol issues get out of whack. With TRT doses, one, I guess, when do you think that it makes sense to start prescribing somebody TRT? And then two, at the doses that you're prescribing TRT, are there health consequences, like if somebody was taking massive doses of, like a bodybuilder would, of testosterone?
Yeah, it's a good
There's
question.
so many questions because I also wanted to be like, you also
probably 6 questions at once.
Well, I wanted to say also, you probably aren't prescribing TRT right off the back. You probably do like AIs and different different protocols that aren't just jumping right into TRT, I would guess. But in relation to TRT, my original question, Stan, if you can remember them, because I've been asking too many questions at one time. Sorry.
Yeah, it depends. First, I'd like to find the root cause. And this is kind of another topic, but we can always go into this too, is I consider myself someone who practices functional medicine, of which there are many functional medicine providers in the city. But what functional medicine is supposed to be is finding the root cause of a pathology and addressing and treating it. And what functional medicine has become is learning the different cookie cutter protocols for whatever else. If you have SIBO or bacterial overgrowth in your gut, you have gut symptoms, then you take this cookie cutter protocol of antibiotics and do that. Or if you have hypothyroidism, you do this cookie cutter natural thyroid regimen instead of the endocrinologist's cookie cutter synthetic thyroid regimen. So what I like to do is find the root cause and then see if it's addressable, and then explain the risks and benefits. Again, that shared decision making of addressing it one way or addressing it via replacement. For some people, depending on where they are in life, a lot of times, as you mentioned, maybe they want to have fertility. So one of the first things I do is, if you have low testosterone, often you also have suboptimal sperm counts or motility. So I test that.
Okay.
How much does somebody fear if they do have, let's say, low testosterone and they're going to do some form of replacement therapy? How much should they fear their ability to have offspring?
Probably not as much as they think, but I wouldn't want to say that to the general public. There have been many offspring conceived for men on TRT and also full blast steroid cycles or TRT plus, whatever you want to call it, not on any HCG or gonadotropin or minotropins or anything.
Wow. No other support.
Correct. I'd say for men on true replacement doses of testosterone, about 50% of the time, they lose the sperm in the semen.
I want to change gears a little bit back to when we were talking about TikTok earlier, Kyle. How amazing it can be as far as getting like the word out on something and it being really popular. The issue we've been talking about in a few of our other podcasts. We recently just had Jeremy Potvin, who's a 4-time Olympia competitor. He's going to be competing again this year. And, he's taken a handful of different things along the way, and he wasn't shy about telling any of those things. But unfortunately, he talks about also how old he was when he started, versus, the 16, 17-year-olds that you're going to see on TikTok that are looking to, they're buying peptides, they're buying things that they can get easily online and not knowing about any of the long-term effects that goes with this. So my question to you specifically on this topic is, are you seeing these people being more and more interested, this younger generation on TikTok, interested in what you do and how you do it, or are they skipping over the smartest people they could possibly be talking to and listening to a YouTube personality or
the Trend Twins? Is this who you're referencing?
Dude, honest to God, like I should know who these people are, but I just don't. I don't know who's
I had somebody in the
anymore.
store the other day say, "Oh, do you not know who the Trend Twins are?" And I said, "No, I actually don't. I'm sorry."
Yeah, I think Sam Sulik is another guy.
That's actually who we brought up on the podcast with Jeremy. Yeah. And he was just like, "Yeah, man." He's like, "That's just ungodly dangerous."
Yeah, I'm not sure how old he is, but that's a good question. It kind of goes along the lines of your question, which is about people who are doing full blast or maybe even just TRT plus, and let's say they take their ancillaries, their cookie cutter ancillaries, what damage are they doing? And the damage that is below the iceberg or below the surface of the ocean is often the most insidious. So let's say they have a predisposition for blood clots, then that's going to be a pretty negative long-term effect. Let's say they have a predisposition to have an aneurysm, then that slightly increased blood pressure is going to have a pretty negative effect, or the slightly thicker blood. Let's say they have a predisposition to have very high ApoB or Lp(a). Maybe they don't have a heart attack, maybe they don't have a stroke, but maybe they have ischemic dementia, which is basically just the small arteries in the brain. They get some neurodegenerative disease where they have cognitive impairment of age, and they won't know that until they're 70 or 80, but they can still get that. Maybe they have ED when they're 70, not because of nitric oxide or whatnot, but because of plaque. Just like you can get plaque in your coronaries and your heart, you can get plaque in the arteries that lead to the genitals as well. So there's a lot of side effects that people can have that they just never know about. But obviously there's benefits as well. So if it's someone like Jeremy, that's his profession, and within a profession, sometimes there's things that you have to do. For example, being a physician, if you deliver babies, you have to wake up at night and do night shifts, and that's terrible for your health as well.
Comes with the territory, if you will.
Yeah.
There's also this correlation I want to talk about with people who are using these, let's say these TRT plus, like you're talking about. There was a time where you could get these things orally and not injectable. I mean, they were sold over the counter. Talk about the I guess the drawbacks or the side effects. Which one would you actually consider?
SARMs are still sold over the counter, aren't they?
Like Superdrol or Methyltren.
That's what I'm talking about. More methylated products.
That's a throwback.
Yeah, P-Plex, Tren. I mean, you could buy all those things over the counter. When me and Kyle were first working our stores, we sold a product that had Superdrol. We sold Superdrol. We sold Tren and P-Plex.
Imdrol. All the goods.
But like, would you consider what people are able to access now through a form of peptide, et cetera? Would you consider those actually healthier than what used to be sold over the counter?
In some ways, yes, and in some ways, no. SARMs are really interesting because they certainly have efficacy for the intended purpose of taking them, which is often accruing lean body mass. But in some in vitro studies where they biopsy this is a case study, not just in vitro. They did a case study. There was an individual who was taking SARMs, I forget which one, but they biopsied his muscle, and the androgen receptors in the muscle had downregulated, which is very strange because general with any androgen, that's going to cause a positive feedback loop, which is where it upregulates the density of androgen receptors in your muscle. So taking SARMs might make you less reactive to your endogenous androgens or to other androgens. but that effect might be reversible. So we don't know that yet. So in that way, I would say they're probably less desirable than pro-hormones. But in some ways, for example, there's not as many people walking around that are just jaundiced and look yellow because they're taking SARMs, whereas that's certainly the case with a lot of pro-hormones like Superdrol.
Are SARMs still being studied? I know that like clinically, they for the most part were deemed to serve no real benefit. Weren't they used for cancer patients? They were trying to retain muscle tissue in cancer patients, and they didn't have the negative consequences on like prostate growth, correct? But then why specifically did they get thrown out, and what are the negative side effects associated with them? Because I think SARMs are still relatively popular with the younger demographic.
Yeah, and I think it's only a matter of time until a SARM, probably enobosarm. I love the naming of different chemicals and whatnot, but
For sure.
you have a research chemical name, which is usually a pattern of letters. For example, MK2866. And then it gets a second name, ostarine, and then it gets a third name, enobosarm. And enobosarm is being studied in cancer patients. Technically, it's being studied in androgen receptor positive triple negative breast cancer, which basically means breast cancer that's not responsive to estrogen. Because usually, most breast cancers are responsive to estrogen, they're called ER positive. Androgens would shrink the breast cancer. That's why we used to use masterone and other old school androgens for breast cancer patients. But this is kind of the opposite. You want less androgen receptor activation. Androgens can actually grow some types of breast cancer. So giving them ostarine, enobosarm, is a way to prevent that cachexia, which is muscle wasting with the cancer, and also decrease the growth of the cancer, which is fantastic for that rare group of patients. And I think it is also particularly promising for prostate cancer patients, partly just because it lowers SHBG so much. SHBG is your enemy in prostate cancer. It also lowers testosterone, which is kind of the mainstay of prostate cancer treatment, is decreasing the receptor activation of the androgen receptor in the prostate. So it would certainly help with that. And then on top of that, muscle wasting is also an issue with prostate cancer.
Is that the reason that most SARMs kind of got, I guess, shelved? Is that they were promised at one point to not suppress testosterone, and basically over time it had been shown that they actually do indeed suppress testosterone.
Yeah, I'm working on writing a paper with a few colleagues now that we're trying to publish, and it goes over a few of those concepts and how that used to be. Like you didn't need a PCT if you did a SARM cycle. That
when SARMs came out, there was like, this is basically gold. Look at this thing. It's not going to suppress your testosterone. It doesn't affect liver, yada, yada, yada. It was like healthiest thing ever. That was quickly kind of like shot down.
Yeah. They're definitely promising, but just like androgens, not all are created equal. So methinolone or primobolan that certainly has a very different safety profile from drostanolone, which I believe is masterone.
Yeah.
So they have very different safety profiles, and each SARM is unique. I guess I could say which ones that I've seen patients take and have better and worse luck, but I'd probably just say the right advice to give is they're very promising, but as of yet, the potential harm outweighs whatever potential benefit that they might have.
For sure. I want to kind of switch subjects here because we've talked a lot about male testosterone replacement and hormone replacement. Can you talk a little bit about the benefits to female hormone replacement?
Yeah, definitely. Most of my clients are female. Females happen to have a pathology called menopause that all of them get. So again, very high demand for high quality healthcare. When you give them estrogen replacement, there's a few cookie cutter regimens. So you go to some place and you just get pellets, and not everybody's a good candidate for a pellet. And really subcutaneous therapy has kind of like negated the need for pellet therapy. There's all the upsides and less downsides. Then you have troches. So you go to your functional clinic or whatnot, and they give you some troches and they're fast in, fast out, but you're not having that steady state around the clock benefit that replacing estrogen with, say, a patch or a cream or even injections, subcutaneous injections would have. And then you have what your traditional medical system likes to give female patients, and that in general is patches, which I actually love, unless a patient really doesn't like them. And then progesterone capsules, which I also like. But when you give a female that, if they are not androgen dominant, so for females, maybe they have PCOS and really high androgens and their adrenals are really active, after menopause, the ovaries do still produce some testosterone in some females, but the adrenals take the grunt of that work. So if the adrenals are producing a lot, then that can be benefit. But in my experience, more than 50% of females have significant testosterone suppression. If I was being mean, then I would call this chemical castration of females. And oral contraceptive pills are actually kind of similar. They're just synthetic hormone replacement therapy. That's literally all they are. So,
what are your thoughts on birth control? Because I've seen a ton of people coming out recently, basically somewhat bashing it as far as being bad for you long term. What are your thoughts on birth control?
Yeah, as I mentioned, it's just synthetic hormone replacement therapy. So there's definitely a lot of benefits to it. One of the greatest benefit that you can have from any contraceptive, which of course is not unique to hormonal contraceptive or oral contraceptive pills, is being able to have a child or not have a child at the right time of life. And obviously, birth control pills do not have 100% efficacy, but they can help. So that's a benefit that for some people outweighs any risk, especially if that individual is not considering any other forms of contraception. So with that out of the way, the downsides of oral contraception are very similar to the downsides of hormone replacement therapy. One of them is increased incidence of blood clots, which is slight, but if you give enough people pills like this, it is a risk, especially with synthetic estrogens. There is progestin-only contraceptives, and yes, we do have it's called the O pill. It's norgestrel, a mix of levonorgestrel and so the levo and the dextro enantiomer, and it will be over-the-counter in early 2024. So over-the-counter birth control pills, not combined, but progestin only are coming, and they did pick the best possible progestin. So good job for picking the best one. And I guess what they're thinking is if you go to a walk-in clinic or you go to your local GP and you ask for a contraceptive and you say, I need a contraceptive because I don't want to conceive a child, then there's a very high chance that they'll give you one. So I guess they figure we'll just pick the best one that has relatively equal efficacy and just let people get it over the counter instead.
How does that compare with things like there's like, the IUD, right? There's like the bar you can just put into someone's like arm. I don't know what the hell. I mean, I'm a guy, but so apologize to any ladies that I'm totally butchering the names. But how do these things compare individually compared to what you're saying is going to be sold over the counter?
The efficacy for IUDs and the implant, which is called Nexplanon, it used to be called Implanon, and then before that they had another one that was even worse. The implant they finally kind of got right, but a lot of women are traumatized because the previous couple of generations of implants had quite a few complications. The implant has the best efficacy. So if you're a female and you just absolutely want 99.99% efficacy, I will not conceive a child, the implant is a great option. Obviously, it does have a fairly significant amount of systemic progestin in it. The IUDs, there's hormonal ones, and they're actually kind of similar to the pill. They also have norgestrel, and they have slightly less systemic. It does go systemic, but it has slightly less systemic exposure to the synthetic progestin, which is a synthetic progesterone. The non-hormonal is a copper IUD, and that kind of has other upsides and downsides. It can be used as emergency contraception, but more often than the other IUD, it does not. It usually prevents ovulation, but not always. So it's kind of an ethical discussion that each woman can have with their healthcare provider. So past that, there's some other options. There's patches, like a Twirl patch, and that kind of has similar upsides and downsides, but slightly less side effects than the birth control pill because it skips first pass metabolism in the liver. So I like to say that I wish that a lot of people would give, a lot of doctors, I don't want to blame the people, obviously it's not their job, I wish a lot of doctors would give as much thought to a menstrual cycle or a birth control cycle as bodybuilding coaches would give to a steroid cycle, and there would be a lot better choices when it comes to contraception. But the again, in the 1,000-foot view rule of thumb, contraceptives are good for contraception. If you need to go on hormone replacement, or if you have like hypothalamic amenorrhea, then you're better off just addressing the root cause.
Do you think when it comes to birth control and how much it's widely used now, do you think that's playing a part in couples' inability to conceive? This is not, I've looked into zero data on this. This is just like me noticing, like in my friend group and people that I'm around, that it seems harder and harder for people to conceive a child right now. And I don't know if that's because of birth control or if it's, outside factors. What are your thoughts on that?
Yeah, multiple factors. That's a great question. Often you see individuals on birth control, and for 6 to 12 months, they still haven't gotten that cycle regularity and enough of LH and subsequent progesterone peaks to have optimal fertility. There's also a lot of third factor causes. Poor sperm motility is one of them. But you definitely see in the 6 to 12 months after birth control a slightly more difficult time getting pregnant. There, of course, as always, there's the argument correlation versus causation. Is this just correlated with it? Which a lot of times it is. It's very common to see, 15, 13, even 12-year-old females come into the office and they say, hey, my sisters had these symptoms. They had the acne, PCOS symptoms, whatnot, and heavy periods, irregular periods, and the doctor put both of them on a birth control pill, and I need the same thing. And you check labs, and they have fulminant metabolic syndrome and very strong PCOS with androgen dominance and insulin resistance, and they had menarche, which is first period at age 10. So it's like basically precocious puberty at that point. Mm-hmm. And in one world, you see individuals like that be on birth control for 12 years. They get married, they're in their later 20s, and they expect things to somehow be normal, but instead they go back to how they were. So that was really covering up the problem the whole time. That's part of it. And then you see other cases. For example, I had a patient that was on a medication that they thought was birth control. They had a history of endometriosis, and they were on a GnRH agonist. And in that case, that's just not an oral contraceptive, and they didn't realize it. And GnRH agonists at very high doses, whether it's Lupron or whether it's Orilissa, can also have delayed effects of subfertility or infertility. So there's a lot of contributing causes with it, but I do think that, certainly birth control is one of the reasons why there's more subfertility and infertility now. I don't think it's because that there's birth control in the water. There is, but at very low levels. Mm-hmm. But that's one of the causes.
Yeah, the birth control in the water is what's lowering testosterone. That's what the conspiracy theorists say.
Our food as well. Yeah. It's like I was going to, I don't know if we're going to go down that path or not, but I'm like, man, from somebody who tries not to watch the news because it feels like it's someone taking somebody else's problems and trying to make them my problems.
It's one of the pillars of health, dude.
Yeah,
you shouldn't watch the news because it's going to definitely raise stress.
I agree.
Yeah. And so with that being said, there's just the amount of information out there. You don't know what to believe if you're a common person living your life, So my question to you is, where would you go to get the absolute best facts on how to treat your body long term? If you are a normal person who doesn't.
That's where you plug your podcast.
Hold on. That is a genuinely good, that's a good answer. But I'm saying for someone who does not know how to read a medical journal, how do you feel like you should go about this?
Yeah,
plug away, by the way.
Yeah, it's a really good question. And yeah, they can look at the Gillett Health podcast and whatnot. And there is many other high quality science-based podcasts as well. Peter Attia's podcast is one, Lex Friedman's one, Huberman is one. But it depends on how likely they are to want to go a bit more in depth. There's a lot of people, some people call themselves biohackers or health coaches, but a lot of people in the fitness industry develop a fairly robust knowledge, even if it's just literally watching more plates, more dates. They develop a fairly robust knowledge, and they know things that their general doctor might not, whether it's about TRT or whether it's about migraines with aura and what contraceptive you might not want to use. But if that's the case, I like Mayo Clinic proceedings a lot, and Google Scholar is great. Rather than Googling things, just use Google Scholar. And obviously you have to parse out a lot of the data, but there's not really a go-to source. There's a lot of organizations that are trying to do a good job, like Exercise is Medicine. CrossFit has their CrossFit Health Initiative. Amy West is one of the head docs there, and she does a great job as well. But there's not really one go-to source.
I'm with you.
I read Peter Attia's newest book, Outlive, and that was a book that made me go, I need to be paying more attention and probably get a doctor that's, in line with like actually, because I feel like most regular doctors that you go to, they're just going to kind of run you, like you were saying at the beginning of this podcast, they just kind of run you through the like, well, do you feel bad? Tap on your knee a couple times, do some blood work, and then you're out the door, And it's like if
algorithm as well.
And if you actually take your health seriously, it's like you in today's world, you need to educate yourself, and you need to have a base level of knowledge that's a little bit higher to be able to ask those questions, because a lot of doctors are not going to come out and ask you, hey, do you want to get tested for, to see where ApoB is? It's like, they're not going to ask you those things. They're going to, a lot of times they'll say, well, you're pretty young and you seem like you're in pretty good health. You work out all the time, and they kind of,
just a whole lot of active listening.
Push you on. I got a question for you. So, we do own a supplement store, right? That's what we do. And, I have heard you talk, on Huberman's podcast about different products that you really like. You've mentioned that creatine being, a supplement that you really like for helping with increasing testosterone, helping cognition. Also Long Jack and Fedosia, both. Can you kind of go through, like, I guess what you personally, because you're in good shape, you obviously lift, and what you personally take on a regular basis and why you take it, and if you would recommend that for other people.
Yeah, definitely. As you mentioned, creatine is kind of like a low-hanging fruit. It's a great addition. One of the things that I like to mention about creatine that not everybody thinks about is its cognitive benefit appears to be mostly over the age of 50. So the older you get,
learned that.
The more creatine tends to benefit you from like a memory and recall standpoint. And I try to take creatine as much as possible, because a lot of people do know it saturates in the muscle. So if you take it consistently every day, it certainly works a lot better. It's not like a pre-workout where you can take it and get some degree of ergogenic benefit that specific day and then stop it. So consistently on creatine, depending on what your homocysteine does, which is basically a product. There's a homocysteine methionine cycle. For most people, they can just think of this as an inflammatory marker. They don't want it to build up because they want to activate their B vitamins well. They want to have normal epigenetic change and modulation. You could be a candidate for slightly more creatine or similar methyl donors, like methylated Bs.
Real quick, is that why I've had many people over the years that they'll come back in, they'll say, I'm not a responder to creatine. So you're saying basically everybody is a responder to creatine. It's just that they might need more creatine.
Probably so. They might not feel the ergogenic benefit, and they might not feel the water retention. Maybe they already tend to retain water fairly well. That's one of the benefits that creatine can give. But potentially you would feel the benefit slightly more if you needed a methyl donor. So MTHFR is the gene. Most individuals have at least 2 polymorphisms. So think of those as high and low functioning genes. So I have 2 of 4 high functioning, 2 of 4 low functioning. And in general, my homocysteine does not run extremely high, even though I eat a ton of protein. So a lot of methionine in the diet. You think about dairy and animal products, has a lot of methionine in it and a lot of leucine in it. But specifically to that, if you have 3 or even 4, you're more likely, and know those 2 genes and 4 alleles. So 2 genes, one from maternal, one from paternal. There's a lot more genes other than that that can affect the function of that MTHFR gene. And there's other genes in that methionine homocysteine cycle as well. but those are just the highest yield ones that we have. Sometimes we do a full genome sequencing on patients, but it kind of depends. And that's something that most people can check with their 23andMe, I think, or just any genetic testing service. But yeah, that's a good start. Next, you mentioned long jack and what was
Fedosia,
and then what I do. And I've talked about these a lot on podcasts, but
you don't have to go in super depth because obviously if you guys want to listen to him explain it in depth, Huberman's podcast is where I originally heard you talk about these.
Yeah. And I've probably done like an hour-long deep dive on the Gillett Health podcast too. But specifically with the long jack, that's also known as Tomcat, or also some people just call it like uripeptides. Uricomanone is likely the active ingredient that is part of uripeptides. So with uripeptides, that might be, 20 to 30% of the content. And then there's things called standardizations. So you can have, I call it an over-standardization, where you have slightly more uricomanone content. We used to think it's an aromatase inhibitor, kind of like D-chiroinositol or boron, but it does not appear to be an aromatase inhibitor. It appears to be a couple different things, but for example, possibly a SERM, but very likely it does work on the steroidogenesis cascade directly. And it's also probably a phytoandrogen, similar to how soy is a phytoestrogen. So long jack, in general, is at a 1% standardization. There's a couple different brand name ones. Probably not worth it to go with the brand name in most situations, but it is worth it to, and I think my friend Derek, I think he posts the HPLC data on his Tomcat now, right at 1%. Could be wrong. But you definitely want to go to a reputable company that third party tests it. There's also a feud between the two countries, Malaysia and Indonesia, that have most of the supply of long jack, and they publish small journal articles that are kind of like
fighting with each other about who's better standardization.
So I might have this backwards, but Malaysia published an article about how Indonesian Tomcat is genotoxic, which a lot of things you can show as genotoxic in vitro. And then Indonesia published about how Malaysian Tomcat is contaminated with heavy metals. So
is that also, you're also able to do that relatively easy to show that as well?
There's a lot of ways that you could get around it. I guess depending on your ethics, that would show how easy it would be to do. I think it would be easier to show something as genotoxic than to put heavy metals in, assuming that you did not just choose a sample that you knew had heavy metals or even put heavy metals in.
Right.
So if somebody starts taking this, how much would it increase their testosterone realistically?
If they have a very low insulin and IGF-1, those are two of the other hormones that upregulate similar parts in the steroidogenesis cascade. And if they have a very low DHEA sulfate, which is a good general marker of adrenal function, and yes, Tomcat does work both in the gonads, so ovary and testes, and also adrenals, then they can have a pretty robust response. It's hard to say exactly, but in general, I'd say it's reasonable to see a total increase of maybe 50 or 100 if they already have a higher insulin, IGF-1, and DHEA sulfate. They'll probably see no benefit, but they might feel that phytoandrogen benefit. So they might feel the Tomcat more almost like a stimulant, almost like when you take a androgen pre-workout.
Oh, yeah.
Yeah.
Mm-hmm. So just a little bit of a boost.
Yeah, nothing like a actual pre-workout androgen.
Yeah. But are you when you raise your testosterone, 50 to 100, like you just said, is that going to be something that's super noticeable? Like, is it increasing your body's ability to go, to synthesize protein? Is it going to increase, max strength levels, energy throughout the day, or sex, drive? What specifically is somebody going to notice from that kind of jump in testosterone?
If you go from 200 to 350, a lot of people who are very androgen sensitive notice a huge difference. A lot of people who are androgen insensitive. A lot of people who are androgen sensitive, which is both the density of the androgen receptor in various tissues and the sensitivity, which is largely due to the number of CAG repeats. CAG repeats are in a lot of diseases like Huntington's disease, Fragile X, but that doesn't matter as much. Just think about it as if your protein is not folded right, the actual receptor protein, then it requires more testosterone to bind to it to get that effect. The analogy I use is the receptor is the door, and us males all inherit. We have an X chromosome and a Y chromosome. Androgen receptors on the X chromosome.
It's controversial now, brother.
So whichever, and I assume we all have X and Y chromosomes, but whichever one that we happen to inherit from our mother, just like we inherit our mitochondria from our mother, we get our X chromosome from our mother. And yes, there's crossing over between X and Y chromosomes, but not in the area of CAG repeats. Then that determines how sensitive we are. So that's like if you have a very insensitive receptor, for example, the hyper extreme would be androgen insensitivity syndrome. You're XY, but you develop and you look like a female, usually a tall female, sometimes attractive. There's a bunch of celebrities who are supposedly AIS or androgen insensitivity, but that's a door that never opens. You can also have a very heavy metal door. Let's say that's 30 or 35 repeats. One disease called Kennedy's disease is a whole bunch of different androgen repeats. And that's where it's very hard to open. And then if you have very few, you tend to be prone to hair loss. You tend to have more, beard growth, prostate cancer, but also respond to androgens and require lower levels to feel good. So if you feel good at a lower level, it's either because you have really good density or really good sensitivity or both.
Very interesting. So Jeff, that's what you got going on with your hair loss.
You can also test your levels, and what I've seen anecdotally, and yes, if you look at the statistics, you tend to have more hair loss if you have fewer repeats or a more sensitive receptor, but it's not as close of a correlation as I'd think.
Speaking of hair loss, I've watched Derek's videos on slowing down hair loss. Jeff here has been dealing with some hair loss, and do you have anything that he could take that would help him with it? I know you're going to come at me.
I have just as much hair as Kyle.
That's true. We both are thinning out.
The truth is we're both 35, 36 and just doing classic male pattern hair loss. So receding, right? I take finasteride, 1 milligram, and that's it. I mean, I was told by my doctor that if I were to be using a finasteride, right, that you would not need to use more or less Rogaine. What's that stuff called? Help me out.
Minoxidil.
That's what I take. Minoxidil. It's in the shampoo that Derek recommends. Or I don't know if he still does this. This was a while ago.
Sure. But you could use that. And he was like, well, if you're going to use finasteride, he's like, I wouldn't take that extra step, is what my doctor said.
Yeah. We have a company called Intelligent, and we have a non-greasy minoxidil and a ketoconazole shampoo called volumizing, because you can't call it ketoconazole for whatever reason. But anyway, there's a lot of ways to think about hair loss prevention. And this kind of goes in with my regimen. The Gillett Health podcast that just came out, I mentioned my regimen, which is HCG. I've talked about my varicose veins and whatnot and testicular atrophy. And again, just like you, I wish that I had checked my levels when I was before the age of 30, but I got into my 30s. And I was like, I should check my levels because I know I've had varicose veins for a while. And I'm pretty sure they're atrophying. So I got ultrasound, sure enough, bilateral atrophy. And I was like, well, I should probably take some HCG, and a lot of benefits from the HCG. My lipoprotein(a), which is associated with plaque buildup, it went down from 100 to 22, and generally you want it below about 50.
Really?
Yeah, but I also run very low on estrogen. So pretty much no matter what I do, my estrogen's always really low. My DHT is really high. Several years ago, before I started dutasteride, and I've taken finasteride as well. Mm-hmm. In fact, I did an experiment when after we had our last kid in the postpartum phase. You go through pelvic rest, and I was like, let's see if we can control the desires and whatnot a little bit. Let's see what happens if I take both dutasteride and finasteride. Finasteride tends to be more concentrated in type 2 5-alpha reductase, which happens to be in genital skin, which can be good, especially if you're very sensitive. So it's sometimes a treatment for premature ejaculation. And by the way, a good rule of thumb is if you're circumcised or you don't have foreskin, then a lot of times you're less sensitive. And if you do have that, then a lot of times you're more sensitive. But dutasteride is not at a high concentration at normal doses in that skin. It's in non-genital skins, like the skin of your scalp or the skin of your face. My skin is way better when I'm on dutasteride. I'm not now because I'm washing out, because And again, this is maybe too personal, but most people listening probably don't care. Not necessarily done having kids. I'm young, so that's an individualized regimen in general. Within 6 months of desiring conception, I recommend stopping dutasteride, and within about 3 months of desiring conception, stopping finasteride. That way it gives them enough time to wash out, and you're not concerned about genomic or epigenetic changes. It takes about 2 months to make a sperm. Mm-hmm. So I kind of like going back to the hair loss question from that tangent. In general, you want an anti-androgen and plus or minus a growth agonist. If you have significant thinning, then oftentimes you do benefit greatly from a growth agonist like minoxidil or like PRP or like latanoprost or its cousins. There's a lot of different growth agonists, peptides, foams, BPC-157 foam. All those things are going to help with the growth of the hair. Microneedling is another one. Arguably a third category to add in if you want to be a hyper responder to whatever your regimen is microtrauma. So whether that's 100 injections when you get PRP, whether that's skin pin microneedling, whether it's using Derrick's Intelligent microneedler, whether it's using dermaroller. I like microneedling over dermarolling personally, but a lot of people see great regrowth when they have a pretty consistent protocol for years. And I've seen some pretty fantastic regrowth as well. So especially in the crown area, that's where Gillettes tend to get it.
Yeah.
But you were doing you're saying you saw that growth really well from PRP.
None of the regrowth or benefit was from PRP.
Sorry, what was that? What were you getting that from?
Dutasteride,
and
some finasteride off and on. Yeah, actually not minoxidil, but I have been pretty good about using ketoconazole shampoo once or twice a week. Makes my hair really frizzy, but I guess
it's not great for like making your hair nice, but
makes it very frizzy. Yeah. But it kind of just comes with the territory, and fortunately, not too many people care about like how frizzy my hair is.
Yeah,
I just feel like since I talk about hair, then I want to have good hair. Like maybe I would get a hair transplant at some point. People are always putting in the comments that I have a hair system because it kind of looks like I have a toupee, but I don't. But I wouldn't be opposed to getting a transplant. I have plenty of donor follicles, so depending on how many donor grafts you have, that's another good option. But yeah, if you just choose one of those three categories, plus or minus a transplant to kind of boost things off. And some people, let's say if I came up with a cookie cutter regimen, someone kind of in your scenario, I guess it'd be reasonable to do PRP just once a month for 3 months and then add in a growth agonist. Unless you have a preference of something exotic, then why not do minoxidil? Oral minoxidil is actually more efficacious. But if you do oral minoxidil, you will want to choose dutasteride over finasteride because it's way better for preventing chest and back hair growth. So even since being off dutasteride, I noticed that the hair on my chest and back is growing significantly more. I'm like, I don't like this. And I don't like the acne that comes with it. Dutasteride can really help prevent acne, especially for people with high DHEAs. So there's a lot of benefits to dutasteride. It's just unfortunate that it does decrease sperm counts.
Yeah.
You mentioned BPC-157, the cream. I was told over the weekend that BPC-157 was taken off the market, or that they've now told you're not allowed to sell that anymore.
Well, it's always been a gray peptide, right?
It's always in the gray zone. You hear this a lot. So you hear this with oxandrin, which is oxandrolone, used to be called Anavar. Mm-hmm. And that's probably because SARMs are eventually going to be approved for similar uses. A lot of times things just happen to be taken off the market before some other competing product gets put on the market.
So, weird.
Yeah, I wonder who's in charge of that.
Yeah. But with BPC-157, it's definitely been targeted because it's generally overused. It is extremely helpful, and a lot of individuals use it in order to help with angiogenesis. So it can help with VEGF signaling, that's vascular endothelial growth factor. And as a rule of thumb, whatever you're trying to heal, the less vascularized it is, the better the BPC is going to help. If you think about it, let's say you get PRP for your plantar fasciitis or PRP for your a ligament in the shoulder. PRP has VEGF in it. It's technically a cytokine. It's inflammatory. That's why you want things to swell if you get PRP. So if you get PRP for your scalp, you actually want it to swell and look red and be inflamed. And you're like, oh, wow, this is bad reaction, bad shot. And it's the same thing with BPC-157. It's why we don't recommend icing as much, because if you ice hardcore on something that's not even going to swell that painfully anyway,
you're taking away the inflammation response.
Yeah. Mm-hmm. You're taking away the leaky capillaries. The leaky capillaries leak out platelets and basically platelet-rich plasma. Actually, it's not platelet-rich plasma or platelet-poor plasma. It's just plasma.
Yeah.
And that's going to have the same growth factors and the same cytokines like VEGF, that things like BPC 157 and also, GHK copper peptide is a good bioidentical peptide that can be used as well. TB500 is chopped up thymosin beta 4 from the thymus. That's probably one reason why kids heal better. So I guess we don't need those peptides. Just go get a $300 PRP treatment from your doctor every two to three times a week for 6 weeks.
Is that site dependent, PRP?
Yes, very site dependent.
Yeah.
But yeah, obviously it's more convenient to have your doctor prescribe something like BPC 157 for $150 from a reputable compounding pharmacy than to get $5,000 of PRP treatment.
Is BPC 157 does your stomach denature when you take it orally, or do you have to take it subcutaneously?
Some people think there is benefit to taking it orally, but the only patients I have on BPC 157 capsules are patients with a Crohn's flare. And I don't even like them to be on it continuously, because treatment for colon cancer is the opposite of BPC 157, called Avastin, which is a VEGF inhibitor.
Yeah, that's the one thing that they say about BPC 157 is that it can cause cancer growth. And is that valid? Is there validity to that?
It's certainly a valid concern. Mm-hmm. Avastin is on the World Health Organization's list of essential medications. It might also make you more likely to have a retinopathy, especially if you're diabetic, because again, more VEGF. Avastin's how you treat diabetic retinopathy. So it's certainly a concern, but there is a happy medium to everything. So
you mentioned, so please continue.
Yeah. In general, injecting BPC 157 is what you'd want to do.
With I was told all this over the weekend based on my sister has Crohn's. So you mentioned that, and they were like, "Well, you should take BPC 157." And there's a fear that I could have Crohn's potentially, right? My fiance has UC, ulcerative colitis, and they were like, "Yeah, she should be taking BPC 157 too." Now, and I'm not asking for any kind of yeah. So here's where I'm at. Where it comes, I'm not asking for any kind of prescription here, but it's just a simple matter of you're saying with a flare, right? If she's having a UC flare, do you see that compound that being beneficial to her?
It can be not as beneficial as low dose naltrexone or LDN, and there's decent evidence for that. And there's gastroenterologists that I work with that are completely on board with that as part of the plan as well. It depends on the patient, but in general, I have not recommended BPC 157 as a preventive for inflammatory bowel disease like Crohn's or ulcerative colitis yet.
I'm with you. Okay.
Switching topics. Your obesity doctor. America is consistently getting worse and worse with obesity. What do you see the future like for Americans, and what do you think, like, are products like Ozempic the future for like moderating obesity and trying to cap it off and stop it from continuously growing like it has over basically the last 50 years?
Yeah, what I see as the trend is in about 10 years or 20 years, we have the Netflix documentary Dope Sick now, but yeah, in 10 or 20 years, we'll have the Netflix documentary Ozemp Sick.
It's a good, hey, listen, you should get that right now, man. You need to trademark that right now. And
yeah, that would be a good one.
So what's the negatives behind it? Everyone thinks it's just magic. Is it not just magic?
Yeah. So GLP-1s are actually growth hormone releasing peptides. Growth hormone levels go up significantly, and that's why you see cancer risk go up in a dose dependent manner. It seems like everyone is on them that does not need to be on them. Most compounded semaglutide is prescribed at med spas. So like your esthetician who's doing your Botox injections is prescribing it. And I guess that
correct, which has always been like, what?
Yeah. And I do both of those things too, but my primary specialty is obesity medicine. And then I've learned on the side to do aesthetics and whatnot. But a lot of times it's a telemedicine clinic or like some startup where your GLP-1 is included in the price of your subscription. So you know that you're going to get a GLP-1, and it does not help you learn the lifestyle factors that go, so it does not help you learn the pillars of health. It's not going to improve your dietary choices. It'll decrease the amount that you eat, but it's not going to help with evidence-based habit formation so that when you come off of it, you don't rebound. That's why 2/3 of people that come off of it rebound. And in some studies, up to 90% of people rebound. The less you teach them how to diet and exercise and sleep properly, the more they tend to rebound. And you definitely don't want someone to be exposed to a high dose of this over a long period of time unless the benefit outweighs the risk. So for a diabetic that has a BMI of 40 or 50, morbid obesity, then their cancer risk is going to be much higher if they're in that poor metabolic state of health. And they're more likely to die from complications from the diabetes. So the benefit definitely outweighs the risk in that case. But if someone's at a normal weight and just wants to be shredded and requires a high dose to stay at 6% body fat year round, then that's not a good case for use.
What's the main issue with if you were to stay on it long term? Like what's the risk profile of it, and what's the side effects that are going to happen to you?
Similar risk from just taking growth hormone long term. If you're on, let's say
really
on 5 IUs of HGH each evening, significantly higher risk of thyroid carcinoma. Even think Dallas McCarver.
I was literally just about to say that.
Yep, Dave Palumbo, I believe, thyroid carcinoma. Lots of GH-induced thyroid carcinomas, and we'll see a lot of those from high doses of GLP-1s. Again, it's dose dependent, especially with double and triple agonists. So like GLP-GIP, now there's a GLP-GIP glucagon, a triple agonist. That is going to have an extremely high secretion of growth hormone and a much higher increased risk of cancer. But besides that, there's also a lot of biliary dysfunction. So cholecystitis is a known risk, inflammation of the gallbladder. But the gallbladder in general, there's tubes that connect the gallbladder, the pancreas, and the liver, and they're all connected. And think of them as a river and tributaries. And as that sludge builds up and that peristalsis and gastroparesis is part of that, all that gastroparesis risk, which is the newest risk, which is the paralysis of the stomach. Diabetics can also get that. That's just where it does not flow downstream and pump. And part of that's just due to less food. So if you went on a diet that is a similar calorie diet, often you do that and you're consuming these huge amounts of fiber. So your stretch receptors bind and your stomach knows to pump it along, because otherwise you're starving even worse. But if you go on a high dose of a GLP-1, let's say you're on 2 mgs of semaglutide or 2.4 mgs, then you can literally just not eat and you won't feel starving. So you won't have those natural processes pumping things down the river, and they'll get blocked up, just like when you dam up a stream.
Okay, so Ozempic, not the future of weight loss. Do you see anything in the medical field that is promising that could be a medication for weight loss in the future?
There's no such thing as too good to be true. I think that GLP-1s are the best that we're going to get. SGLT2s are decent, especially for people that are at low risk of UTIs and yeast infections. And they basically, you pee out sugar. So you can see why you get yeast infections and UTIs. Low doses of GLP-1s with interdisciplinary clinic. If you need dietary advice, then you have a nutritionist or a dietitian. We have a sports dietitian who's excellent that works with us. And if you need exercise advice, then you have a trainer, physio, or a strength and conditioning coach, someone that can teach you the basics of that. And if you need to improve your sleep, then you improve your sleep. And ideally, you do this as a household unit. So everybody in the house goes through together. It's been my experience that, fortunately, my wife in general is healthier than me. She thinks I'm a hypochondriac too, but usually you kind of the least healthy person drags someone down. Obviously, that's not always the case, but often it's the same way if you're trying to quit drinking alcohol, quit smoking, quit eating sugar. If you do it as an entire house, it just works way better. So low doses of GLP-1s is a tool. The analogy to make along with that is it's like you're going through the course of life and you get caught in quicksand. Maybe it's mostly genetic, maybe it's minimally genetic, doesn't really matter. GLP-1s are a crane or a backhoe that can get you out. Everything else is a shovel, other supplements and medications, they're weaker. But the downside of that is if you don't move, if you don't learn how to continue going and learn new habits, then you're going to sink back in that same quicksand.
Literally what we tell people in the store every day. There is no, unfortunately, there is no, quick fix to any of this outside of habit changing.
With that being said, I want to give you a fun exercise. So you've helped formulate many products now. If you were to create a product to help with people creating these better habits, what would you put in it?
And it could be regarded like, you mentioned alcohol, cigarettes, you mentioned, maybe sleep better, maybe not eat as much, which I feel like is the 4 pillar, or it's similar to like what your 4 pillars are as far as health goes. Maybe reduce stress, help with cortisol levels.
Yeah, it's a good question. If I could put medication in it, I'd probably put 0.5 or 1 mg of naltrexone, like a ultra low dose naltrexone. Past that,
can I ask why that is though for the listener?
So it's a non-selective opioid receptor antagonist. So kappa, mu, and delta. You think of mu opioid receptors, that's what has to do with respiratory suppression, but it also works in the gut, so it helps with peristalsis. So that's one thing that I like, but it can help modulate these receptors in the brain that are responsive to dopamine. So if you specifically have binge eating, or you have that dopaminergic reward that comes with that, it actually blunts that response. So it's not necessarily causing dysphoria, but it causes less of that feedback or less of that reward. That's why it's also used in alcohol use. It decreases that euphoric feeling that you can get from that. Depending on the availability of that kappa opioid receptor in what's called your limbic system, which is your emotional system of the brain. It's your amygdala, it's your hippocampus, part of your hypothalamus as well. Then you can be a hyper or a hypo responder to a regimen like that. But yeah, it's also nice if you're just not eating a whole lot to have something that helps with peristalsis continue. That way you don't get as much constipation. Most appetite suppressants have constipation that goes along with it. It would be reasonable to put in ashwagandha, like a KSM 66 as well.
For the cortisol purposes, or, the testosterone increase?
Partly just it seems to be serotonergic as well. Something to help with mood support as you do it. You could even put in rhodiola, although that does not have a well-defined mechanism. Anecdotally, it seems to work relatively well. That'd be reasonable to put in. If it was a supplement in the evening, a lot of times as you're in a caloric deficit, you're going through new habits, you tend to have trouble sleeping too. And then you're like, all right, well, let's just have a snack, and then I'll probably feel tired after I have, whatever carb heavy snack that you
Something's
have.
going to fill you up, yeah.
Yeah. I'd be tempted to put in a low dose of an orexin inhibitor. So you have two kind of opposing centers in your hypothalamus, which is one of the main control areas in your brainstem. You have your anorexigenic signaling, which is exactly what it seems like. You're not hungry. You can be anorexic. You can have anorexia without being anorexic. Then you're orexigenic. You're hungry, you're awake, and you're angry. I call it the hangry center. And a lot of times if you do respond and you're really sleepy after you eat, and that helps you go to sleep at night, your sleep quality and your sleep architecture is poor, but it does help you get to sleep. So that's why there's multiple different sleep medications that are orexin inhibitors. And they do tend to be weight negative, not by a lot, but by a couple pounds, even when you just control them with placebo. So people not trying to lose weight, they tend to weigh less than the placebo group if they're taking that. So that would be reasonable to...
What are those specifically? What are the names of them?
There's 3 of them. One is Qvivic, that's a dual inhibitor. One is Dayvigo, again, a dual inhibitor. And Belsomra is kind of the original one, which is a single inhibitor.
How cool, man. Yeah, we're going to put that together.
Yeah.
I'll give you a royalty.
Unfortunately, 2 of them are prescription
I was
only.
about to say, well, we can't sell them. He'd have to do.
Yeah. I'd love to be affiliated with a nonprofit pharmaceutical company at some point. There's nonprofit companies that like relabel supplements that are made in other countries or medications, but there's not an actual nonprofit pharmaceutical company that's formulating new medications, running clinical trials, et cetera.
To make healthcare more affordable.
Yeah, because, correct me if I'm wrong, but would not the pharmaceutical industry give that company the boot in some way or another through
Be going against some giants.
Yeah, it's worth a try.
Yeah, I think so, man. Something we ask everybody we have on our podcast, which we haven't had one lighthearted discussion yet. My God.
Dude, I could sit here and just ask you questions all day.
I know, man. Well, I mean, we appreciate you being here, and these are the questions I think only you're going to be the only guest we've ever had that could answer them. So really do appreciate you being on here. But we always ask everybody, who, especially with you being from Kansas City, born and raised, when people come in town to see you, let's say, where is the barbecue spot that you have to take them?
I take it to Jack Stack.
That's your go-to?
That's a good one. What are you getting at Jack Stack? What's the favorite thing there?
I get the Jack's Best.
Oh, nice.
What's the Jack's Best? I don't know this.
I feel like the Jack's Best is the 3 meat, right?
Crown prime rib, smoked, 3 meat, and then ribs and burnt ends.
Their burnt ends are really good. Have you ever had their wings?
I have.
Their wings are really
the
good.
Fire-kissed wings are the best wings in town.
They are good.
They're
They're
very
really
good.
We had a guy this weekend. We had a camp out with all of our managers for the whole company in one spot. And they hired a barbecue crew to come out, and a trailer and everything. They did a whole day's worth of catering, right? And these guys this is crazy. It was $40 a head for the catering. I was like, damn.
Wow.
They went all out. Yeah. And so they were just giving out like tons of stuff throughout the day, just sliced Wagyu. Yeah. And just handing it out to everybody throughout the day. And one of the things they did was they had Wagyu burnt ends, and I had never had one of those before. And I was like, well, I don't know how you top that, right? Like, it was just unbelievable. I mean, every burn end's good, but this was just, it was unreal. Anywho, appreciate your time, dude.
Tell everybody where they can follow you and keep up with everything that you're working on.
Yeah, my main hub is Instagram, Kyle Gillett MD. As I mentioned, we have a new podcast and YouTube channel that we're trying to promote. And that's
Gillett Health?
Gillett Health, yeah. There's kind of 2 categories of episodes. One's called After Hours, and that is intended for entertainment and very lighthearted. And then the other ones are more clinically oriented, which people still might enjoy listening to. And then, all other platforms, it's just Gillett Health.
Very cool,
and to
man.
be clear, Gillett is Gillett.
Yes.
No E on the end.
Correct.
Make sure everybody else here knows that. Cool.
Thank you again for coming, man. I really appreciate it.
Sincerely. Thanks
Thank
so
you
much
guys.
for your time, man.
My pleasure.
Appreciate it.